Abhishek, who all are answering?
Good evening, sir. Sir, I think Manas is answering, sir. Manas and Yasir called me, sir. Yasir said he has some emergency, won't be able to answer. Ojas will be answering, sir, and myself, sir.
Yasser is also answering.
No, sir, Yasir won't be answering, sir.
Okay, so you and
Sir, myself, Ojas and Manas, sir. Manas
okay, Manas
Panda.
is answering this time. Good, good. So which are the main instrument?
Sir, starting, sir, we can complete in 2 sessions, sir. I think starting से लेके sir फिर urethrotomy, PCNL, वो सब sir
No,
पूरा
I don't
TUR,
want all
VUR.
the instruments. I will show you so you can
Yes, sir.
answer. Huh? Okay.
Yes, sir. Okay, no problem, sir.
Gite sir has joined. Pankaj has joined.
Yes, sir. I joined, sir. Good evening, sir.
Good evening. So, Pankaj and Gite sir, what do you think? We should start with the basic, that cystoscope, then all that URP instruments, and then we go ahead. I have got the instruments,
Yes, sir.
so we'll start
Usually
first.
it is at the it usually it is at the end of the examination, and at that time majority things is already decided. So it is what usually examiner will do is he will give either TURP, sheath and obturator and ask TURP as a one procedure. So one procedure and one instrument and one X-ray. These are and one specimen. These are the four things. If examiner usually give one instrument and ask procedure related to that instrument, usually such thing happens. But sometimes he may ask different also. सो प्रोसीजर का भी एक टेबल आया हुआ है सर, जिसमें अपन इनको इनसे छोटे छोटे जो रूटीन ऑपरेशंस है वो स्टेप वाइज अपन नेक्स्ट सेशन में या नेक्स्ट टू नेक्स्ट सेशन में करा के ले सकते हैं.
No, we can have one more session. Next time we are going to have how much time is going to take for
1 hour. I have given 1 hour for overview of research, because that
okay,
is one table nowadays added in DNB as a end of the examination subspecialty and recent advances and research methodology. So just I have requested that pharmacology professor to have an overview of research in short period, that is 1 hour में करने के लिए बोला है.
fine. So then we will continue instruments on Tuesday after that, or in between. I think Tuesday
वैसा
after
है
that,
सर, आप
because
जैसा
that
बोले
day.
वैसा. अगर इनिशियली उसका एक बार का हो गया तो he will get free and continue, we will continue after that if remaining instruments are there also.
Okay, so half research methodology, and then followed by we will have instruments.
Remaining any instruments. Okay.
Yes. Okay, Paras.
And every time
Hello, yes, sir.
so it is better to have different people answer at different place, different time, because every time अगर ओजस अभिषेक के दो ही प्रेजेंट कर रहे तो बाकी लोगों को भी थोड़ा आगे आके बात करना चाहिए. सडनली एग्जाम में उनके लिए डिफिकल्टी हो जाएगा. So I request rest of the people please come forward and try to answer, because this platform is made only to do mistakes here only. Hello.
Yeah.
Pankaj sir is busy with his some personal problems. So
Okay.
in between he will
Yes,
be
yes. He told me
chipping.
the same thing.
Yeah.
I'm trying to convey him the message, but in this my son's Mac, it becomes a little difficult. We wait for 2-3 minutes and then we start it.
Ji sir.
You can all see now, na instruments.
Yes, sir.
Abhishek,
Yes, sir. I can see.
you can make out.
Uh,
You can see it, na?
yes, sir. I can see it. Yes, sir. Yes, sir.
Okay, okay,
Yes,
okay.
sir.
Fine. I'll come close also. So don't worry.
Right, sir.
Just wait for two minutes and then we'll start.
Okay.
Hiren has joined. Paras. Hiren sir was busy or he's free now? Nayan, you are answering today?
Yes, sir. Yes, sir. I am there, sir, today.
Very good. And what about Asutosh?
Ashutosh, sir, I think.
Sir, Dr. Nayan will answer first.
Yeah,
Hello.
Nayan is there.
Yes, sir.
Abhishek is there. Ojas is there.
Yes,
Anyone else want to volunteer?
sir. Yasir was also there. Yasir.
I got a phone call from Yasir. He has some emergency, so he won't be able to answer.
Okay. Anyone else who is there?
Manas, I think, is answering, sir.
Manas, you are answering?
Yes, sir. I am also there, sir.
Very good. Okay. Gite
Hiren sir.
Hiren has joined. Paras, Hiren, you finish your case today?
Yes, sir. Finished.
So he's at home only, na?
Hiren sir is not there.
He has not joined. Na? Okay.
मैं कॉल करता हूँ सर.
हाँ, कॉल करके पूछ ले. Because
आगे ज्वाइन हो
there
ये ज्वाइन
domain-
ये ज्वाइन
join हो गया. Okay. Okay. Hiren,
Yes, sir.
गुड इवनिंग
so
सर
how was
Good evening.
how it went? All went very good.
Yes, sir. Yes, sir.
Good.
Perfect. Yes, sir.
Sorry, I could not
No,
join.
sir. No worries. I couldn't come for the class because yesterday I had asked Achin the timing, but he said that sir will tell. And then I had kept an appointment at 12:30 and 1 because transplant was there.
Oh, yeah.
So afternoon appointments I preponed them. So I couldn't, last moment I couldn't change it. Sir.
You missed Dabeli, nothing else. Okay, I think we should start now.
Yes, sir. Yes.
Because this is your domain, your and Pankaj, both of you
Yes,
are
sir.
very good. So we can go ahead with that. Even Dr. Hudedar is there. Today, I want Dr. Hudedar, Sir ji, aap bhi thoda kuch, you ask them questions. Okay? Fine. Okay. So we'll start with someone new, either Manas or who else is there?
Yes, sir. Nayan, sir.
Rajesh is there, na?
Dr. Nayan sir.
No, Dr. Nayan and Dr. Manas. So let's start first with Manas, then we will go to Nayan and then to our old people.
Yes, sir.
Okay, Manas, can you all see this instrument?
Yes, sir. Yes,
Yeah.
I can see. Yeah, it's a. It's the 4 mm telescope. Yes, red tape. So it's a 4 mm 30-degree telescope. The parts being the eyepiece, body, and the light post. The body of the telescope is consisting of the rod lens system. The light post is the place for the attachment of the light cable, and the eyepiece consists of the viewing area to which the camera can be attached.
Okay. Hiren, want to ask any question to him?
I'm not able to see the instrument, sir. I don't know why.
Sir was holding the instrument actually, sir.
Acha, acha, okay.
So,
Building, na?
first
No, it
simple
is not.
simple question is how the telescope is classified depending on the viewing angle.
Yes, sir. There are four. It can be categorized into four types: 0 degree, 30 degree, 70 degree, and 120 degree telescopes.
And 12 degree.
Yes, sir. And 12 degree, 5. Yes, sir. And it has color coding, which is there on the light post. According to that, the 0 degree is green, red is 30 degree, 70 degree is yellow, 120 degree is
White.
white, 12 degree I don't recollect, sir.
Black.
Black.
Okay, then what is the other?
So how they were used as per the sites?
The 0 degree is used for urethrotomy and for while crushing stones in case of when we are using alligator forceps in the bladder, in the bladder stones. And 30 degree scope is the normal scope which is used, is the most commonly used scope which is used for cystoscopy and during TURP. During cystoscopy, it is used to view the posterior and the anterolateral bladder walls. 70 degree scope is used for viewing of the dome, and 120 degree scope can be used for the viewing of the more anterior portions of the wall.
So 0 degrees for the when you want to have a cylindrical vision.
Yes, sir.
Whenever you want to have vision in lumen. Okay.
Yes,
in such places, because it is direct end viewing vision, so it is helpful in doing procedure and visualizing the cylindrical part, that is lumen of the urethra.
yes,
okay. 30 degree is usually used for the trigone and posterior lateral wall of the bladder. 70 degree is usually used for the bladder dome, and 120 degree is used for to visualize the anterior part of the bladder neck.
Yes, sir.
Anterior bladder neck.
Okay. So Manas, one more indication of 0 degree.
So during VIU, we use 0 degree. And any procedures in the urethra, if you are doing, then it is better to use 0 degree, like breaking a stone, if at all we are breaking in the urethra, or if we are doing fulguration of the posterior urethral valve fulguration, 0 degree or 12 degree, a lesser angle would be preferred.
Fine. And what are the uses of 30 degree?
The 30 degree is used for cystoscopy, for transurethral resection of bladder tumor or transurethral resection of the prostate, and any like breaking of the stone in cystolithotripsy, cystolithopaxy, and for stenting, and for all. Yes.
Manas, in 0 degree, the angle of viewing is 0.
Yes, sir.
Okay, so you can see only in front of your in front of your telescope.
Yes, sir.
No on the sides. So angle of viewing and field of viewing is same.
Yes,
in
sir.
30 degree, the angle of vision is 30, but the field of vision is, if you divide vertically straight from in front, 30 degree on right side and 30 degree on left side. So the field of vision is 60 degree, 30
Yes,
on right and 30 on left. But for 0 degree, it is 0, 0 only. So angle of vision and field of vision are different for 30 degree, 70 degree, 120 degree, but same for the 0 degree. So whenever you want to use the telescope in cavity, that 30, 70 and 120 is useful. And when you want to use a telescope in lumen or in any tunnel, then 0 is useful.
Yes, sir.
So what is the size of the telescope?
Sir,
and length of the telescope?
Yes, sir. Normally we use 4 mm telescopes. There are 3 mm telescopes also available, and the length of the telescope is 20 centimeters. Sir.
Okay, and how that image is formed?
Sir, it is a
how you
20
can able
centimeter?
to see
Are you
through the
sure?
telescope?
20 centimeter?
the
Okay,
20 centimeter up to the
30 centimeter. It is 30 centimeter. 30. It is a 4 mm 30 centimeter.
okay,
Hmm.
30.
What is the advantage of 120-degree telescope? When the indication when you will use it?
Sir, if we are suspecting any anterior, when we are doing a checkscopy and we are suspecting any, small tumors which can be missed in the anterior.
Yeah. So tumors which are situated at 12 o'clock position at bladder neck, if
Yes,
you
sir.
want to visualize them and resect properly, that is
Yes.
the only the telescope which is useful
Yes, sir.
in TURBT.
Yes, sir.
So the how the vision is developed using which system?
The rod lens system.
Correct.
Sure.
Yes, sir.
So what is difference between the Hopkins rodless system and conventional rodless system?
Sir, the amount of glass and air in the Hopkins initial. Hello.
हाँ सुन रहा हूँ बोलो.
In the
Yes.
initial rod lens system, it was more column of air which was there, and the smaller pieces of lenses were used. In the advanced, in the recent modification, the glass.
देखो sir has kept a picture. Sir has kept a picture on screen.
Yes, sir.
And in upper picture, uppermost picture is of conventional telescope.
Yes, sir.
So what is the conventional telescope? The glass rod acts like a lens in upper system.
Yes, sir.
Okay.
And here the air.
Lower system is Hopkins rod lens telescope system, where the air space acts like a lens.
Yes, sir.
This is the major difference. Here,
Yes.
lens is air is act like a lens, and their glass rod is act like a lens.
Yes,
This is the important difference. That's why
That is Hopkins 2
system, the image resolution is very poor. Yeah, it is Hopkins 2 and better image resolution.
Yeah.
Yes, sir.
Okay, so I have measured the length also. It is 30 inches. I mean,
30
12
centimeters.
inches.
Yes, sir. It was my mistake.
So it is 30 centimeter. Okay.
And
Yes,
the
sir.
second previous picture, sir. Second picture, what sir has shown, already I have explained what is 0 degree, 30 degree, and 70 degree.
Field of vision, sir.
Field of vision and angle of vision. These are two different things.
Yes, sir.
Okay. So now,
Yes, sir. Yes, sir. It is a cystoscope sheath. 19 French cystoscope sheath. Green colored label is there. So the parts are the body and the shaft. The shaft is oblong. Shaft has a tip which is a beak curved upwards, which prevents injury to the urethra during introduction. The lower part of the tip is open for around 2 to 3 centimeters for the introduction of the telescope and for other accessories. And the length of the shaft is 24 centimeters.
9
22.
inches.
Dekho, Manas.
Yes, sir.
So you just imagine there is a cystoscope sheath in your hand and
Yes,
try
the
to.
bridge is 4
9
centimeters
inches.
and this is 26 centimeters. Yes, sir. Bridge is 4 centimeters and this is 26 centimeters.
So adult
And
cystoscope
totally,
is regardless of size. It may be of any size. It is
Yes,
a 22 centimeters.
22. Yes, sir.
Okay. So when if you imagine, so first is cystoscope sheath, beak The distal part
It is
is
about 22 centimeter, and if you consider the whole thing,
it is
up to the
26.
body, it is about you
26.
can say it, about 27,
26. It is 26.
26. So
Yeah.
total will be 26 from
Yes.
here to here,
4 centimeter bridge.
26,
That makes 30
and the
centimeters.
only this is 20. Okay.
Okay, sir.
So the cystoscope sheath is divided into first is beak, then inlet, outlet vent, then color code disc. Sir may show there. Then numbering on the sheath, Abraham lever and cystoscope sheath. So these are the classification. These are the parts of the cystoscopy sheath. Okay. So
So now
standard
can you see
length.
what is written on that? Can you read it?
19 and 4, 4 and 5 will be written.
Okay.
What is the meaning
So
of that?
if you zoom the lower picture.
17.
Yeah,
So that-
17. What else?
1 into 5, 2 into 4.
What is the meaning of that?
Sir, if with a bridge, two instruments or four French lumens diameter instruments can be introduced, and 5 French can be introduced, sir.
Fine.
The distal 2 is for two largest ureteric catheter with bridge कौन सा जाता है वो distal 2 राउंड के लिए है, और जो proximal राउंड है वो 1 largest कितने नंबर का जाता है?
5.
हाँ, so these are the 3 points, and just in front of that there is a size of the cystoscope sheath. So there are 4 points at the base, that is size of the cystoscope sheath. Then just proximal to that there are 2 points. So that 2 points indicates the largest 2 ureteric catheter size कौन सा जाता है वो है, और उसके फिर proximally 1 है, गोल राउंड है, तो वो that is for largest single ureteric catheter कौन से size का जाएगा sheath से, वो उसका marking है. Then aside of that inlet and outflow.
Yes, sir. It is two
What is
channels.
here? 0. Right.
2 channels with lever lock system for the inlet of water, inlet or outlet, either can be used.
Sir has asked what is that 0? Mark 0 on sheet.
The 0 is for alignment, sir. It is for alignment of the bridge on the cystoscope sheath.
And then
0 coincide with
the 0
bridge. 12 o'clock side of the bridge.
Yes, sir.
And the important point here is the distal
and anti-clockwise it is allowed.
Distal most, if you see carefully, distal most 10 centimeter is without marking.
Yes, sir.
Because,
and proximal 13 centimeter is marking 1 centimeter apart.
Yes, sir.
And if you have given a 2 sheet, one is of VIU and one is of cystoscope, the difference between 2 is marking is from tip.
In the VIU sheet, the
in
entire
the VIU sheet.
Yes, sir.
Here there is no marking for distal 10 centimeter.
Yes, sir. And the tip is also different in a VIU sheet, sir.
Yeah.
Yeah.
Flat-ended, and this has a beak.
And again, 17 degree sheath and rest of the sheath are different.
So which are the sizes you get?
17, 15, 17, 19, 20, 22, and 25.
No. You cannot mix the old and new systems. So the new system is what? 17, 20, 22, 25. 19, 21 others are old system, right?
Yes,
so
sir.
Manas, can you use the VIU sheet to do cystoscopy?
Sir, the introduction with an obturator which comes with a VIU sheet can be done, and then it can be
but
used.
I want you to visualize the urethra. Can you use it?
Sir, it will be traumatic to use the VIU sheet for visualization of the urethra.
Okay, you have introduced. Now, what will you do? How will you do cystoscopy?
Sir, the 30-degree scope cannot be used because the tip of the scope will cover the. There is no hole at the.
So normally we use it with the working element, right?
Yes, sir. 0
So
degree.
now working element is not there. Suppose 0 degree. So can you use it? No.
He is asking you a question. If you want to use this thing VIU sheath without working element, how will you use it?
There's a long bridge.
There is another bridge which is available, which is
Long bridge
longer
is
than
Yes.
this bridge.
Yeah,
Okay.
yeah.
Understood? So even
You must know it, Manas. There is a longer bridge available. The normal bridge will not fit into the VIU sheath. It is short, the bridge. So there is a longer bridge available. So if you keep your VIU sheath and 20 French sheath and see, the VIU sheath is shorter. So therefore your normal bridge will not fit in that. And normally they ask you this in the exam. So you should know that there is a longer bridge available.
Can you see? Okay.
Yeah.
See, sir is showing. See. So therefore the bridge is longer, Manas.
Yes, sir. Yes.
Yeah.
Okay. So now, finally,
Sir, two, three more important point again.
Yeah. You ask about the different sheets, na? The uses.
So the marking is why marking is made on the cystoscope sheet is to measure the prostatic urethral length. That is one indication for marking. Another thing is what is meant by female cystoscope sheath, or what is meant by female cystoscope.
The 17 French sheath is usually used for female.
So next question is, what is difference between 17 French and rest of the sheath?
Sir, the distal end of the sheath is different. There is one more opening. There are two channels, one for water passage and one for scope passage separately. So while withdrawing the scope, the urethra remains patent, and it is easier to visualize when using a 17 French sheath because the channel is different.
And the length of beak in 17 French scope,
compared to 2.5 centimeter in a normal.
2 centimeter in 17 and rest all have 2.5 centimeter.
Yes, sir.
So तो फीमेल सिस्टोस्कोप का क्वेश्चन पूछ सकते हैं. आगे सर, आगे देखो. हेलो.
Hello.
हाँ सर.
The next one.
जी सर. Next one.
Sir, this is a single channel, double channel cystoscopy bridge.
Why it is called bridge?
Sir, it is used in between the cystoscopy sheath and the telescope.
So it bridges or connects the
two ends of the proximal end of the cystoscopy sheet to the scope.
Okay. Just show me the align. Why there are two different?
Sir, there are two locking mechanisms. The distal locking mechanism is to attach to the cystoscopy sheath, and the proximal one is for the telescope. There are two channels for introduction.
No, you are talking exactly opposite.
Sir, the
proximal and distal from where?
Sir, distal end of the bridge attaches to the proximal end of the cystoscopy sheath. No, that is proximal, sir.
Proximal to you, but proximal, it is distal for the body of the patient.
Yes, sir. Distal for the body of the patient.
You are entering like this. Correct?
Yes.
Entering like this. So this is
for the cystoscopy sheath.
Proximal end.
Yes, sir. Okay. And the other end for the attachment to the telescope to the telescope to the cystoscopy bridge. There are two channels. The two channels are for simultaneous introduction of two ureteric catheters can be done according to the size of the sheath which we are using.
Why you are talking only of ureteric?
Any instrument which are of any instrument. Any
Any
instrument
instrument
or
can be used. Are there different sizes?
size of bridge one. Just sir had mentioned that for the
Only
VIU
the length. Only the
length is
length.
around
Not
length
women
is
by
4 centimeter. Length of the bridge is 4 centimeters.
6 centimeter. It is 6 centimeter. Adult cystoscopy bridge are usually universal and can fit into any size of the sheath.
Yes, sir. But I think it is 4 centimeters. I'll confirm and get back to you, sir.
You confirm?
नहीं, इधर मेरे पास ruler है.
तो गिन लो sir.
It is
4
2.5 inches and 1 centimeter. So I think it is 6 centimeter.
6 centimeters.
Okay, sir.
Okay.
So what are the advantages of detached? What is meant by integrated cystoscope?
Yeah, it comes with bridge.
Yes, sir. It comes. It does not need a bridge for the attachment of the cystoscope. It does not need a bridge for the attachment to a cystoscope sheath.
There is bridge, but bridge and telescope cannot be detached.
They are integrated. Yes, sir. Like in pediatric scopes, they come.
So what are the advantage of detachable bridge?
Sir, we can use single channel or multi-channel, and we can use the cystoscopy sheath for drainage of the bladder, or we can attach the LX evacuator to the cystoscopy sheath, and it can be used for evacuation of any clots or any particles in the bladder. Also, larger lumen catheters can be used for dilatation if we are doing urethric dilatation.
If you want to empty the bladder, is it possible with integrated?
No, sir.
So it is possible.
It is possible.
Remove either.
Yes,
open the channel, na?
Sir,
remove the water and open the channel, it will drain and aspirate it.
Slowly. Okay. Now, what are the uses of cystoscopy? Manas, what are the uses of cystoscopy?
Sir, for visualization of the bladder wall, for
always say here diagnostic and
treatment.
Therapeutic. So,
sir, for diagnostic purposes, it can be used to diagnose any obstruction, bladder outlet obstruction, like strictured urethra, or diagnosis of any obstruction by the prostate, bilobar or trilobar enlargement of the prostate, or visualization of the bladder wall to rule out cystitis, or for taking biopsies from the biopsy of the bladder wall, of the bladder mucosa, and from multiple sites, and for visualization of a vesical calculus.
Therapeutic.
Therapeutic purposes, sir, it can be cystoscopy can be used.
Forgotten about diagnostic, even in the RGPs, retrograde pylography.
Yes.
If you divide your answer into therapeutic and diagnostic, you'll be able to better do it and go organ wise, urethra, bladder, ureter.
From outside. Always you think that way to do urethroskopy. So in urethra, what you will come to know, if there is any stone or if there is inflammation, if there is any stricture, posterior urethral valves, you go ahead and see the prostatic enlargement and the trilobar enlargement or median lobe enlargement, then go inside the bladder, whether to see any mass, any stone or any inflammation, urethrosil. Then you are doing bilateral, means you are doing RGPs or you are collecting urine. Correct? Now the same thing, now you go for the therapeutic. So what are the therapeutic?
For ablation of the any stricture.
You can do dilatation, na? Visual
Yes,
dilatation. Under vision dilatation you can do. Na?
Visual dilatation of the urethra. Then for treatment of urethral stricture by using laser through the cystoscope.
Yes.
Then for
even posterior valves, fulguration.
posterior urethral valve fulguration. Then for laser cystolithotripsy.
Okay.
Then for introduction of ureteric catheter into the kidney, or for degestenting.
Yes, degestenting for URS. Correct. You want to dilate the ureter, or for
Dilatation of the
PCNL, put the
ureteric.
uretic. Therapeutic, no? For before PCNL also we do.
Yes.
Uretic
Introduction of the
catheter.
ureteric catheter into the kidney before PCNL, dilatation of the vesico-ureteric junction before proceeding for any procedure, and degestenting.
So you should be very quick, you know.
Yes, sir.
As Hiren said very rightly, na? So just say diagnostic, therapeutic, and go. Fine. So I think we change to students now. Manas, you are doing well. So next, Nayan, you are going to answer.
Yes, sir.
Manas,
Sir,
Manas,
आपको
Yes,
हाँ
sir.
बोलो.
2 questions for you. Extended length cystoscope and continuous flow laser cystoscope. ये पढ़ लो.
Yes, sir.
Okay. So Nayan,
Yes, sir.
Tip दिखा दो.
I see the tip of the instrument, sir. Yes, sir. Sir, I think it is a 21 French visual internal VIU sheath, sir. Visual internal urethrotomy sheath.
yeah, tell us the parts.
So the parts are, sir, one, first is the sheath. Sheath is there, sir.
Shaft, okay.
Shaft. Then
There's a body.
body is there, sir.
So
There
what
would
are
be inlet channel, outlet channel, sir. And then there is one also channel for the introduction of.
Which one is the inlet channel and which one is the outlet channel?
Mostly, sir, markings are there into the.
Are you sure?
Usually, sir, right side is inlet and left side is outlet.
Anything can be any channel where you put attached connection, means the saline.
Yes, sir.
Okay, it is inlet and the other will be the outlet. So you close one and open up another.
Yes, sir.
And what is this third one?
Third one is a channel, sir. So that channel can be used to introduce
What
guide
channel?
wire.
It is called what channel? It's the instrument channel. Basically, what do you use?
We can use, sir, guide wire. We can pass
Working
guide
channel,
wire.
you must say working channel.
Working channel. Yes, sir.
Working channel.
So what is the length? What is the length?
Length, sir, I think 25 centimeter.
The shaft, it is 20 centimeter.
Shaft is 20 centimeter.
And this is about 1.5 inch. So it will be
2.5.
about 4 centimeter. So total 24. You understood?
Yes, sir.
So 2 centimeter, 2.5 centimeter, it is smaller than cystoscopy sheath. Understood?
Yes, sir.
What do you see on this? I don't know, it is a little old, but compared to that, can you see some markings? That is what Dr.
Yes,
was talking about. You see it very nice.
Yes, sir. Markings are there, but they are from the beginning of the scope. Like it starts.
Yes.
So there are 20 markings
Yes,
of
sir.
1 centimeter apart. So the length of the sheath is 20 centimeters. So 1 centimeter apart, 20 markings.
Yes, sir.
And size is 21 French. So 1 French is equal to how many millimeter?
0.3 millimeters, sir.
Okay. Correct.
बराबर.
Fine.
The channel size, maximum channel size.
For working elements, sir?
Not working element. This, you are saying that you will pass guide wire or ureteric catheter. So
Working
what
channel. Sir, you are
ureteric catheter, maximum
working
size of ureteric catheter which can be passed? It is written
Uh,
there.
I think, sir, 9 French.
No. It is
बाबू
written there.
इंस्ट्रूमेंट तुम्हारे सामने है ना, देख सकते हो एग्जाम में,
देखो।
it will be right in front of you.
तुम्हारे
This is the instrument, the
लिखा है उसमें।
circle is showing na. Sir, show him again, sir.
This one is the Indian made. I'm sorry, it is not written on
Oh,
there.
that is
But
5 French.
But 5
Maximum
French.
is 5 French.
Yes, maximum is 5 French.
Yeah, stars.
True, sir.
Yeah. Okay. So how will you use it? It is used for what, Nan?
Sir, to to take an incision on urethral strictures under vision. That is called visual internal urethrotomy, sir.
So how will you use it?
First, sir, we have to
Now you diagnose the patient has got stricture. Patient has got a stricture. You have given him anesthesia.
Yes, sir.
You have given him a position, part is clean, drape, everything is ready.
Yes, sir.
Now how will you proceed?
I think, sir, first we will make sure, like, we will go with the smaller sheath of cystoscope, and we will identify the position of the stricture. Then we will pass a guide wire through that stricture, and then we will assemble this VIU sheath.
So what are the instruments you will take for VIU?
First would be, sir, telescope would be there, sir. Our basic telescope would be there, sir. Then
What are the, you just tell me the instruments that you will use.
Yes, sir. Telescope, sir.
Okay.
Then camera, light
Okay.
source.
Okay.
Then inlet channel, like irrigation
You
channel.
didn't mention which telescope. You will use 120 degree?
No, sir, 0 degree, sir.
तो बोलो ना फिर.
0 degree telescope with 17, preferably 17 French sheath with light source, with camera, inlet channel connecting irrigation fluid. I will first do cystoscopy. Then I will identify the location of the stricture, and then I will pass a guide wire through the stricture. Then I will come out, and then I will assemble this VIU sheath.
So tell me now, what are the instruments you will use for a VIU?
Sir, 21 French VIU sheath with 7 centimeter of this long bridge, sir. Then I will attach a telescope to that connection of this
You
sheath.
have already done the cystoscopy. Why you want to take a longer? Directly now you go inside and do VIU. No, you want to do VIU.
Yes, sir.
What about Thatcher's knife?
How you directly go? Because the tip of the 21 French is
Traumatic.
It is not oblique.
Yes, sir.
So here the obturator is required. Theoretically speaking, you can't place the 21 French sheath without obturator.
Yes, sir.
Yes.
If you want to
He
negotiate
has already
the
said. He has already said that he has identified. He has done a scopy. He has identified the stricture. He has put the guide wire. So now what you will do? So what are the instruments you will take? You will take a telescope. You will take a working element, and you will take a
Thatcher's knife.
Knife,
Correct?
sir. Sasha's
Right.
knife, sir. Yes.
So which type of instrument working element you will use? Active,
Sir, it
passive,
could be
thumb, finger. Which one?
Finger operated, sir.
For a
Wire
VIU, which is preferred?
Thumb operated.
Thumb operated, sir.
Why?
Because it gives a better control to the tip of the knife, which is like
Is safer first
Knife,
of all.
knife will remain in the sheath.
sheath.
Yes, that is important point. So knife remain inside the sheath at rest, which will avoid injury to the urethra. That's why the thumb operating working element is preferred. Again, for theoretical purpose, while introducing, we usually introduce with working element. but in exam, when you do initially you do a cystoscopy with 17 French, place the guide wire come out. Then you have to place the 21 French with obturator to avoid the trauma to the meatus.
Yes.
When that is entered inside, then you have to attach your working element to that. This is theoretical answer. Practically, people are doing the thing whatever you are telling.
Yes.
Yes, sir.
Okay, fine. So what are the different methods of cutting the stricture and what fluid you will use? Irrigation fluid. Which irrigation fluid you will use? You will
Irrigation
use
fluids are normal saline.
water.
Correct. Normal.
Why normal saline? Why normal saline? बेटा नयन
Yes, sir.
आंसर दे दे. Even if it is a wrong answer, don't worry.
I think if we use like glycine or something like that, then the extravasation of that fluid, if we are cutting, then that extravasation would lead to the irritation of that, and spongiofibrosis might happen. But NS is usually like
Correct. With isotonic, we always use
Normal.
saline. Okay. Fine. How will you cut it? What are the different ways of cutting?
so usually we have to take a one clean cut, and usually at 12 o'clock, and the adequately like the stricture adequate, like not too deep, but
So you have got a thumb action.
yes,
So
sir.
when you push with the thumb, the knife will
and the knife will come out.
correct?
Yes, sir.
So how will you cut it? With the protrusion of the knife or while retrieving the knife?
There are
Protrusion of the knife while retrieving, sir. Retrieving, we have to make a downwards to upwards movement. And
But if the stricture is so dense, how will you enter without cutting?
Yes, sir.
There are
So what are the different types of knives?
So
There are different
what are the
types.
different types of knife and what are the different types of cutting?
Correct.
You answer this, or Dr. Gite will. If you don't know, explain you.
And when you entered inside, there are 2-3 things you may come across. One is you may see a lumen across. Another is you cannot see, there is only just guide wire is going up, going across. Okay. Third thing is you may see only a ring, hinge ring. So whenever you see a lumen, to accommodate the size of the blade,
yes,
then it is easy job.
Yes.
You have to just place the blade under vision in that lumen, and you have to move whole assembly while withdrawing with 180 degree.
Yes, sir.
So that is a conventional teaching of doing the VIU. Correct? If suppose guide wire is, you see only guide wire is going across, no lumen. So to be on safer side, you dilate that stricture by placing urethral dilators up to 8 French or 10 French, and then cut. That is more safer. In spite of cutting, another way of cutting by cutting a millimeter to millimeter and following the path of wire.
Or you can put ureteric catheter over the guide wire and confirm that urine is coming.
Yes.
And I have a tip. You said that I went inside, I put a guide wire, I did cystoscopy, then I came out, then I did VIU. So what Gite sir is trying to tell you is that you may have different scenarios. You may just have a pinpoint opening. How you are going to do cystoscopy? So when you are asked to describe a VIU procedure, you say that I will go in with the VIU sheath or with the 17 French sheath. I will put in, first best is to say 17 French sheath. You put in a guide wire across the strictured area. Either you dilate it or you cut it with the VIU. Then you will go ahead and do your scopy. Na? You cannot just blindly push through the stricture. You may just leave the urethra. What sir is telling you is different scenarios, how you will approach them. That is how you have to describe in the exam. Then the examiner knows that you know all the different scenarios. Sorry, sir.
Conventionally, there why there is a we will advise to cut at 12 o'clock position. Exactly. So the purpose behind cutting at 12 o'clock position is if you cut deep inadvertently, then that cut may go in between the two corpora.
Corpora.
This is the purpose originally. So that should not got corpora should not get injured.
Yeah.
Correct?
Yes, sir.
So now, in spite of single cut, people were advising multiple cuts at 3 places. And in spite of dorsal cutting, people were advising ventral cutting. That is ventral value. In exam, you tell what is conventional described in the book. But if someone asks, what is meant by ventral value? What are the types of cutting? As like sir is asked. So it is a 12 o'clock cutting, single cutting, sharp cutting, fine cutting. 1. 2. Multiple 3 places cutting, that is 2. And ventral cutting is 3rd. So these are 3 type of cutting. Accepted everywhere. If examiner asks, you should know all 3. Then why ventrally? The concept or pathology in the stricture urethra is spongiofibrosis. Okay. So where is the maximum spongiosa? Dorsally or ventral? Ventral. Yes. So you have to cut ventrally to release the
dense
by the spongiofibrosis. Because spongiosa is more on ventral.
See,
Correct.
on the
So
floor,
that's why
there is no tissue, okay, except the spongiosum. So what will happen? That you will go through and through, and there will be a extravasation. Now, as far as the cutting is concerned, first is like you are pushing. So saw-like movement means the blade will go inside, and again you are retrieving it. So both the time it will cut like a saw. Understood? It is going inside, and you also while retrieving you are cutting. Another thing is you put your knife inside this below the stricture and use external meatus as a fulcrum and then cut it. Understood?
Yes, sir.
So you use it like this. Use this as a fulcrum and cut it.
Yes, sir.
So there are these 2 different methods of using. Now, Dr. Uddedar had asked you, what are the different knives which are available?
So one is this sachet knife is there, sir. Apart from that, there is one circular shaped knife is also there, sir.
Upmoon.
Yes, sir. And
Serrated.
serrated.
Saw-like.
Saw-like knife is there, sir.
Yeah.
So Nayan,
Yes, sir.
so cutting can be done by cold knife. Cutting done by electrical cutting, like to BNI, bladder next stenosis. So it is used with right angle, Collins knife. Another is laser cutting. Okay, in cold cutting, again, sir, already you have described the straight knife, hook knife, cold knife, round, and that another is serrated or Louis knife. So usually what we use is sachets, cold knife, straight.
Correct.
But when you want to do a ventral value, personally, I feel you have to rotate the camera with 180 degree. The whole assembly 180 degree. And if you use the cold knife hook shape, it is very easy. And another thing is, if you want to use that cold knife at the suppose bladder neck stenosis. So which type of cold knife you use?
Then, sir, straight would not help. So circular type or serrated.
Half moon knife. Yeah, circular knife or half moon knife.
Yes,
Half moon knife.
So now the next instrument.
Okay. So
Sir,
you,
one question, sir. There is one half sheet.
Yeah, please.
Half sheet. Do they know that
Yeah.
yeah, they
when
should
it
know.
should be used and when it should be,
They
how
should
it
know.
should be assembled? Half sheet of the
Half moon sheath is there, sir. So if like it is usually used with the assembly, and when we take out the assembly, so it
Yeah.
will there would be a patent tract would be there. So post
Yeah.
procedure, it will be easy
To
to
put
put
catheter, it will be easy. To put catheter, it will be easy.
easy, like post this procedure, because the catheter will directly go into the bladder. For
Yeah.
that thing, it is used.
See,
If
whenever there is a long stricture, if there is a very dense stricture, your sheet will go inside. But
catheter
Foley's
will not go.
catheter will not go.
Correct.
The reason is that it is soft. You understand?
Yes, sir.
And again, the wall will collapse. Because the wall will collapse, the wall will collapse. So your our catheter, if you see, it is thickened at the tip because of the balloon. Understood? So it becomes very difficult, and this is a time you put this half moon. So which number Foley's catheter will go through it?
That is important.
If the sheath is of 21 French, then sir, I think
no.
18,
Listen.
No. Half
20,
sheet.
21 French. You have added half moon to that. So it is 23 French. Outer circumference is 23 French.
Correct.
So 23 French means which catheter will go?
22 will go, sir.
No. But through that half sheet.
Half sheet. 16 French or less. 16 French or less.
16,
14 or 16.
but sometime even with the 16, it becomes very difficult, and you might.
So 14 will be ideal.
14. I will prefer 14.
Yeah.
Okay. Fine. So what are the complications? Final. Come on, Nan.
Yes, sir.
What are the complications and how will you tackle?
Sir, just before that, sir is saying 14 French. Sir is saying 14 French. So is it necessary to place a 22 French catheter after a VIU or a 20 French? What is the ideal size you would place after a VIU?
I think, sir, 16 or 18 French would be sufficient, sir.
Why not a bigger catheter? Why?
What is the purpose of placing the catheter?
Yes, sir, it will the drainage purpose, sir. So where we have taken a cut, that thing will place would heal properly for that purpose, sir.
So you want to drain secretions and allow epithelialization.
If you place snugly fitting catheter, how that secretion will it get drained?
Yeah.
Yes, sir.
Then chances of converting a small stricture in long stricture will be there if you use snugly fitting catheter. Anyhow,
More spongiofibrous.
Yeah, incidence of doing a VIU visual nowadays is gone very tremendously. It is gone down. The indications are very limited.
Now you answer Sir's question.
In the exam also be careful while telling the VIU.
Yes.
It should be very, very short, segmental, filmy, non-dense.
Yes.
Possible. Then only you utter the word VIU. Otherwise, unnecessary you will make problem to yourself. Because person like me, I will not talk about my advice VIU.
So now sir has told you, so what are the indications of when you will do VIU?
Sir, short segment, like around 1 to 1.5 centimeter, like it should be less than that. First time it should be happening, the stricture should be happening for the first time. And usually in young patients, sir, we can advise VIU. Like the stricture should be for the first time, short segment, and there should not be dense fibrosis, sir. Dense, if we are suspecting that there would be some dense spongiofibrosis would be there, then we should not advise VIU, sir.
Dekho.
Which other condition?
Do you want to do VIU in penile urethra?
No, sir, bulbar urethra.
So site is one indication. It should be bulbar.
Bulbar.
length. It should be less than 1 centimeter. Next, there should be very minimum spongiofibrosis.
Correct.
It should be partial stricture or short segmental stricture.
Yes, sir.
Then only you try a single attempt of VIU with a success rate ranging from 25% to 75%. This is a very wide range. In the first VIU, there is a roll up. Another one VIU, that is success rate is with 35%, and there is no roll up third wave.
Yes, sir.
Okay, you should be very clear in your answering.
Yes, sir.
Gite sir, can you give your opinion about core through?
So, urethrotomy is usually done in olden days.
Yeah.
And if you want to core through the stricture, it through a dense fibrosis,
Yeah.
that is going to fail in majority of the cases.
Yes. Yes.
In spite of going for, personally, in my practice of in my institute, there is no role of core through. But
Correct.
in some situation where it is no other thing is possible, if you are in difficulty, you already there is bleeding is there, then you want to place the catheter. It is difficult. Some there is no other way to go for than only.
Yeah.
It is a tackle the crisis situation.
Yes. Same thing is with me.
So Nayan,
Yes, sir.
complication.
Complications would be, sir, first of all, it might bleed, sir, because we are
From
using
where?
a cold.
It will bleed from where?
The site where we are making incision, sir.
When? What is the reason for bleeding? Why you want to cut it at center? One reason Dr. Gite has said. What is another reason?
Another reason is, sir, that because of like inflammation would be there in that place.
Which two arteries are there?
Bulbourethral arteries, sir.
Bulbar.
That will where? Not
11 o'clock and 1 o'clock position, sir.
so. That can bleed like anything.
Yes, sir.
How will you decide? How will you decide if it is sufficient cutting?
That is important. How much deep you should go?
Yeah, how much deep? And if there is a bleeding, how will you stop it?
The deep, I think the fibers of like
will you
corpora
come up to the mucosa or you will go beyond? So, up to you will cut the mucosa or you will
up to like corpora spongiosum should be, sir. The parts of circular fibers of corpora spongiosum should be visible, sir.
Suppose you are placing a cut and now by mistake you have gone deep and you are seeing a sputter now. So now what will you do? Sputter is seen.
You have to relate it with book B.
9 two important points.
Yes, sir.
Fibrosis, always white, no bleed.
Correct.
Whenever there are partial hemorrhages like thing, you have to stop.
Yes.
You should not go deep. That is one thing. If you go deep and bleeding, then you answer that question. Bleeding है तो क्या करेंगे? Spurt दिख रहा है वहाँ पे.
We can, sir. Fulguration, sir, we can try under vision.
We can, what will you do?
ठीक है ना? That your answer is not wrong.
Ideally,
But you should be confident.
Bugby अगर है अपने पास तो.
Yes, sir. Fulguration I can try, and if otherwise I will put a catheter and then I will give a perineal pressure.
Yeah, that is also there.
fine.
Right, perineal compression or pressure I would give, and then I would wait for like pericatheteral and the color of the urine which is coming into the bag, sir.
So shall we go ahead with another instrument with Ojas? You will answer now?
Yes, sir.
Tell me the part.
Ojas and Abhishek are waiting, sir.
I know, but Abhishek का कोई problem नहीं है.
Yes, sir. So this is a continuous flow uh, resectoscope outer sheath, which is 24 or 26 French, uh, because it is yellow coated disc, which has inlet and outlet. There will be arrow markings for the inlet, which goes inside would be the inlet, and the other would be an outlet. Then, uh, yes, sir. And
Rotating, non-rotating.
so it is a rotating one, sir. It's a rotating. And with the ceramic sheath, and it's a rotating. So it is 24 French, a continuous flow, rotating resectoscope, outer sheath plus inner sheath, with a inlet and outlet channel. Yes, sir. So and the there are grooves on the proximal and the distal aspect. On the proximal aspect, there is the groove is for the groove is for the ceramic sheath, and the on the distal aspect. So sorry, on the proximal aspect, it is for the ceramic sheath, and on the distal aspect, it is for the telescope. On the proximal aspect, there are multiple side holes, multiple holes. This is for making it as a continuous element. So while doing the transurethral resection procedure, water flows through this small holes between the inner and the outer sheath. So and can be drained out through the outlet channel. This instrument would be sterilized ideally using an autoclave, or we can use disinfection by using glutaraldehyde solution. This is 24 French or 26, because the color coding is blue, sorry, yellow. And
What is
So
the
you
basic
said that
difference
water will
between
flow.
rotating and non-rotating?
You said water will flow from those small holes. So how is the inlet and how is the outlet? Where is the water coming
Yeah.
in from and where is it going?
yes, sir. So the water from the bladder will flow from the outer sheath through these holes between the outer and the inner sheath, and then it will go out through the outlet.
Very good. So because of those holes,
Yeah.
those tissue is also not coming in, right?
Yes.
Yes, sir.
Yes.
Yes, sir.
Okay. And you
What?
said sterilization can be done by autoclave and disinfection
So
by
water will come
glutaraldehyde.
out from where? Water will come out from these holes, or it will come out from here?
So water from the bladder will go inside the holes between the outer and the inner sheath, then
But that
go
is
through the
outlet.
bladder, come out through
So
the outlet at the
yeah. So
proximal aspect.
these holes are for the outlets,
Yes, sir.
and that
Yes,
is
sir.
why there are multiple holes, so that when the
Yes.
sheep or anything comes near to that sheep, it doesn't get obstructed.
Yes,
And
sir.
that is the reason you always see that when there is a full flow going inside, and even though outlet channel is open, still the bladder will be full,
Yes, sir.
because
Yes.
inlet is always more than the outlet.
Yes, sir.
Therefore, you should always look at
Okay?
the arrows, the inlet and outlet.
Yes.
Yes,
What
sir.
sir
Yes,
is
sir.
telling
There will
by
be
mistake, if
So
you
yeah. In
attach
here,
this,
the inlet,
it is marked.
and you see
Why?
this opening,
Yes, sir.
okay, this opening
Hmm.
in the inner tube. Can you see?
Yeah. Yes, sir. Yes, sir. That is the inner
This,
tube. Yeah.
this is going exactly below the
Outlet
inlet.
channel.
Inlet.
Yeah.
Inlet.
Inlet. Sorry, inlet. Yes, sir.
That is
Inlet.
why
Yes, sir.
when
Sorry.
the fluid comes from here, it
It goes to
enters
the inlet.
into this.
Yes, sir.
So how many channels are there?
Uh, so there are two channels.
How many
Two channel.
channels will be there?
We will say so two inlet, outlet, and one for the telescope. Telescope. So three channels.
Understood.
Yes,
Effectively,
sir.
there will be three channels
Yes, sir.
once you put the telescope.
Yes, sir.
Yeah.
So
Okay.
you said sterilization can be done by steam as well as autoclave and as well as disinfection with glutaraldehyde, correct?
Yes, sir. Yes, sir.
Any other method?
Can you autoclave?
Yes, sir. We can.
Autoclave, sir, he said. Any other method? What is steroid?
Yeah, steroid can also be used, sir. Steroid can also
What
be
is
used.
steroid?
Steroid is yes, sir. Can be
Yeah.
used.
What is steroid?
So steroid is
Plasma sterilization.
okay. Yes, sir. Yes. Plasma steroid.
So there are two machines, plasma, steroid NX and steroid X.
Yes, sir.
So the bigger machine has got 3 or 4 cycles, and it
Yes.
also can be it can also be used for heat sensitive instruments like
Okay.
flexible uretroscopes and other things. So there is a flex
Yes.
cycle. So in
Yes.
42 minutes you can sterilize your instruments.
Okay.
Okay, what is the
Yes.
difference between sterilization and disinfection?
Sterilization involves uh, elimination of all the bacteria, viruses, and including the bacterial spores, all the pathogenic
Correct.
organisms.
All
Whereas
microbiological life, including
life
spores.
along with spores. Whereas
Yes.
disinfection involves will get rid of the live microorganisms, but not necessarily the bacterial spores.
Is there any problem with glutaraldehyde?
So glutaraldehyde will it has to be before the instrument is used. After it is taken out from the glutaraldehyde, it has to be rinsed. Otherwise, it can be irritant to the mucosa.
Yeah, so it has a alkali indicator wherein you must see that the solution is showing the proper indication that
Yes,
it is not contaminated or gone bad.
yes, sir.
Okay,
It should be
and
prepared solution, can be used for 2 weeks. Yeah,
correct.
and
It
should
can
be
be used
labeled.
for 2 weeks, and
Yes.
it has to be constituted in special trays only, which is provided by Johnson and Johnson.
Yes, sir. And it has to
Yeah.
be closed and it has to be rinsed before the instrument is placed in the solution.
Is there any other solution which is used nowadays for disinfection?
Yes, sir. There is a micro
Sodium perboate.
sir. Okay.
That is Paracef.
Paracet.
Yeah, earlier it was marketed by Microgen.
Okay.
Okay, so what happened is that glutaraldehyde used to cause these fumes, and the operating nurses and others would have got
Irritation
health
of the
hazards,
eye.
irritation of eyes, mucous membranes, asthma, and those fumes are irritating. So they have raised some, cases and other things. So therefore, they have stopped using glutaraldehyde and they have started using sodium perboate, or it is also called as Paracef.
Yes, sir.
What is the
So
basic difference
what are
between
the
rotating
steps of
and non-rotating?
Oh, sorry, sir.
Yes, yes, sir. In a rotating resectoscope, the angle of the working element along with the sheath can be changed without disturbing the assembly. So the whole the working element along with the sheath can rotate to help in the resection. Whereas in a
Can rotate.
non-rotating,
Right.
yes, sir. Yes, sir. Yes.
Yes.
Yeah, so in a rotating one, so the working element along with the sheath can rotate inside to help aid in the resection, whereas in a non-rotating will have to disturb the assembly as well. So
Assembly.
it will prevent the coiling of the wires while doing the surgery.
So what is the advantage of non-rotating? You told the advantage of rotating. Now, what is the advantage of non-rotating? Suppose the urethra is very tight and you
Yes,
cannot pass that outer sheath between this one, and you want to use that inner sheath as a conventional resectoscope sheath, you can use it.
Okay. Okay. Yes.
So 2-3 important point related to the resectoscope. First, resectoscope is introduced by which
Visual
person?
observation.
Which person?
An object. Yes, sir.
First resectoscope is introduced by whom?
First resectoscope was introduced by
McCarthy, I think so.
McCarthy.
And Iglesia is another continuous irrigation resectoscope. Iglesia is a student of
McCarthy. Yes, sir.
Okay. So,
Yes, sir.
so the resectoscope size 24-26, is it which color? Yellow. Then 26
720 is black.
is black.
Black.
Yes.
So classification as per the size 24/26, 27/28, or 26/28. Another is short beak and long beak. Another is as per the sheath material, whether the Teflon or MTC. What is by MTC? Nowadays, modern resectoscope is made of MTC. That is metal, ceramic, and Teflon. Okay. Depending upon the irrigation, it is continuous irrigation or it is non-continuous irrigation or conventional. Depending upon size, already
Conventional.
told. Depending upon the beak, long beak and oblique beak. Depending
Short
upon
beak.
the material, already told. Upon the irrigation, also already told. Then
Insulation, insulated and non-insulated.
insulated or non-insulated.
Yeah.
Then
Outer
working element is working element अभी discuss करना है ना?
Yes, sir.
बाकी है.
कर सकते हैं.
Miracles.
Yes.
ठीक है.
So there is active element and passive element. Active element is also known as bomb rocker. And
First,
Let's- sir,
you tell me
sir.
what is this.
Yeah, important.
Going to working element. I'll show you working element. What is this?
so this is a visual obturator which would be inserted into the sheath. Visual obturator. Along with the telescope, the visual obturator and the outer and the inner sheath, we will insert the scope first. Then we will remove the visual obturator, and then along with the working element, the telescope is inserted.
Okay.
With the loop attached.
Why the need of visual obturator?
So because in this the beak will be traumatic to the urethra, so we use a visual obturator which has a traumatic end. So initially introduction with a visual obturator, and then switch over to a working element along with the attached loop.
So what is meant by that? किसका नाम है उसको? Which name of the visualizing obturator?
I don't.
Schmidt, I think.
Huh?
Schmidt's visualizing
Yeah.
operators.
Yeah, yes. Schmidt. SCHMIEDT. SCHMIDT.
Schmidt visual.
What are the other types of obturator?
It's a blind obturator. Then those which are used. So in a obturator will have a cystoscope.
The type of blind obturator.
Timber
So
net
blind
state.
obturator used in a VIU sheath. So initially we, after assessing the under lubrication, we insert along with
in TURP also, in this also you get a
Why-
non-visualizing
Why you
obturator.
want to
So
use?
what are the two types of obturator?
Visualization obturator. Yes.
Why you want to use that obturator with
So what
VIU?
is timber net?
Already discussed VIU, na?
Yes, sir. Okay.
Why you want to use
Dr.
timber net?
Anil Hudedar is telling
VIU?
you which are the two types he is giving you.
What is timber
Sir जी,
net?
आप बोलते हो उनको.
Yeah. So straight obturator. Then one is Timberlake curved obturator, which will help to negotiate the
Correct.
bulbar urethra.
Yes.
These are the two obturators.
And it has got a spring. So from outside, when you press it
Yes.
over here, then that
It can-
obturator will become
Bend and negotiate the curve.
Okay.
Yes.
So these are the two.
Yes.
Now
Kudi shape.
tell us what is
Kudi
this?
tip.
Okay. Yeah. So this is a working element for the, and this is again. Yes, sir. This is active bomb rocker working element for the TURP, which has which is which has the proximal part has a stem for the attachment of the loop or the working instruments, and then moving proximally, we have the groove for the insertion into the outer sheath, and then there is the grip for the thumb and the other one for the four fingers. This is the active element in which the cutting happens by the active movement, where the blade would be where the working part will be outside the sheath. This helps in the advantage being that this helps in the faster surgery. That is the advantage. However, the disadvantage that since the working instrument which is outside the sheath can be traumatic.
Is a single stem or double stem?
So it is double stem.
No, it's a single stem.
Sorry, it's a single stem. Yes, sir. No, single stem. Single stem.
What is which one is better? What are the advantages of single stem over double stem?
I don't know, sir.
See, in a double stem, na,
Yes, sir.
the wire goes here.
Okay. Okay.
Over the two ends will come out from here. So the only one, so on that the wire will go. So always there are chances leakage of the current, number one. Number two, from here, the leakage of water can take place, because
Yes.
after some time
Yes,
it
yes.
will get widened.
Mm.
Okay. Fine. Third, when you are putting the loop inside, these two ends, it may not go properly inside the two different holes, and it may get bent. So the damage to the loop is very common, and the insertion is little difficult. At the same time, if it gets little bent, you cannot attach the wire. Okay. In single loop, as you can see, there is a groove. This holes, can you see it?
Yes, sir.
It is not there in double loop.
Yes.
So this is more steady.
Steady. Yes. Chances of leakage are also less. Yes.
Okay. Because here the current is coming from above.
Yes.
Yes.
So this is more stable. The loop will not rotate.
Yes.
So these are the advantages of
Single step.
step. Okay.
Yes.
Fine. Okay. So, sir, आप question पूछो उनको.
Sir, where the first TURP in India was performed? First TURP surgery in India.
Chennai. I don't know, sir. I don't know.
Medical college, CMC Vellore.
CMC Vellore. Okay.
Yeah.
CMC Vellore.
And Roger Ban, he was.
Okay, Roger Ban. Yes.
So that is by Barnes technique.
Barnes technique, correct.
So 2-3 points again. If your exam is at CMC Vellore, JJ Hospital, Mumbai, Olden place, rack and pinion system is one more system.
Yes.
They may place.
Dr. Ajit Phadke, my teacher, he was using that rack and pinion.
You may not have seen that instrument, but just have a look of the picture of that instrument. And if you want, we have that system in our department, but we usually doesn't place. But some बोल नहीं सकते कोई अगर रखा उसका थोड़ा बहुत ना चाहिए. Then thumb operated is also called as Nesbit, and finger operated is called as bomb rocker. So the advantage and disadvantages, majority you told. The preference of the type of system used is depend upon the experience of the surgeon and preference of the surgeon.
Yes, sir.
So advantage and disadvantages are there of both.
Yes.
क्या करेंगे तो तुम्हारा ट्रेनिंग कैसा होगा उसके ऊपर.
Correct.
Yes. Correct. So for active, if there suppose there is a large gland and you want to take a deep bite, it is possible with active. It is not possible with passive because there are control.
Yes.
Correct.
Totally. Yes.
So these are some important points related to the type of working element, passive and active.
Yes.
Okay.
And important another point is passive can be used as VIU.
Correct. Yes. Yeah.
Loops का तो सर ने बता दिया शायद. Suppose while doing the TURP, the loop got cut.
Yes. So it depends on where it is cut. So if it is cut in the center, the circuit is broken, so it will not help in resection. So we will have to change the loop. But if it is cut at one of the sides, then it can be still used. We have to just change the angle. It can be still used because this case the circuit is still complete. However, the stability will be disturbed. So we will have to change the angle and do it.
Correct. So in another way, the way of telling is if it is cut at the passive arm, matlab non-central arm.
Yes.
Okay. Current will continue to flow. If you cut in the middle part of the curve, that is exactly in the center, then current will get disconnected, and that cannot be used. So that can be used as a right angle.
Collins knife.
So what are the types of loops?
Sir, we have a resecting loop. Then we have Collins knife, and the rolly ball. So that is for hemostasis. College name for TUIP, transurethral incision of prostate, or when bladder neck stenosis is there. Transurethral resection is for resection of the prostate and any bladder tumor or bladder mass. Whereas the cautery is the rolly ball is for the hemostasis.
Fulguration.
Okay. The another way of classifying is thick loop and thin loop as per the size, that is 0.35 mm, 0.25 mm, and 0.40 mm. Thick and thin. Standard. The standard 0.35 mm. Then loop is made up of tungsten wire.
Tungsten.
Okay. And standard loop is of 0.35 mm millimeter.
Yes.
Okay.
Okay.
Okay, so now in the last instrument, and then we go over another thing.
So during TURP again, they may ask the type of irrigation,
Yeah,
then
ask him.
height of irrigation, then amount of absorption per minute, probably then how will you, what is my ricochet bleeding, then how will you identify the venous sinus opening. So these are the questions asked in exam. Whenever there is a TURP set in your hand, then they may ask you to assemble the system. They may ask you to tell the just how will you, what are the instruments you take on the trolley while doing the TURP. Usually people will forgotten the instruments related to the VIU, instrument related to the diagnostic scope initially. So usually वो miss हो जाता है. ये सब चीजें commonly questions है जो पूछते हैं एग्जाम में. तो TURP का अगर आए तो ये सब questions भी आना जरूरी है.
Yes.
Sometimes they may ask you, how will you differentiate between that cord, high frequency cord, which is adult one, which is pediatric one? There is a little difference, technical. You will know it. It's not that difficult.
So most commonly used fluid, bolo.
Most commonly used fluid is glycine, sir. We'll use 2% glycine. This is which is used commonly, and the others could be, we can use distilled water, and then there is mannitol and mannitol plus glycerol.
Distilled water.
Sterile water.
Sorry, sterile water.
तो हमारे पास भी स्टेराइल यूज होता है, हमारे पास ग्लाइसिन नहीं है.
वही तो है. Years together we are using.
And the height should be 60 centimeter. Height should be 60 centimeter. The 60 centimeter.
18 inches from the symphysis pubis of the patient. ऐसा है ना कुछ?
What are the other fluids used में 5% dextrose, mannitol, sorbitol, or a combination of mannitol and sorbitol. So you not use. So you can tell normal saline for if you have bipolar TURP. You can sterile water or 1.5% glycine having a 230 milliosmol per liter is osmolarity. 20 ml per minute is absorbed. Amount of fluid absorbed per minute is 20 ml.
20 ml, correct.
So height of the fluid, height of the that stand is in between. It should be between the 60 to 100, and average it is 70 centimeter height.
70.
Okay.
Means so, from symphysis pubis to this one.
Yes.
Yes, sir. The height.
Symphysis pubis to height. Huh?
For having a good vision, approximately 250 to 300 ml per minute should be the flow required for having good vision.
Yes.
Another thing is that if examiner may ask if you are doing a TURP and there is a bleeding, then how will you tackle the situation?
Yes, sir. So first assess the bleeding. So we will just go behind the bleeder first. So we have to assess whether it's a spurter or it's a venous bleeding. In case of a spurter, we have to we will we'll try to hide the bleeder first, and then
while the bleed, you see a bleeding is coming from right wall, and when you go there, there is no bleeding.
That is ricochet bleeding. So you have to look at the exact opposite side. And then yes, sir. One. Okay. Second is yes, sir.
Another point. If you go to the bleeding, vision is clear. If you go away from the bleeding, there is diffuse wound. Which type of bleeding?
That is
Sir,
venous.
venous.
Venous bleeding. Okay. If the venous channel is got open, how will you tackle?
So venous channel, we will not do anything. We will after controlling all the arterial spurters, we will use
No.
balloon.
So it is depend upon the your status of TURP.
Yeah.
Once a level subject, if it is in early phase, then what you are taking is correct.
Correct.
If you are at ending phase, just remove
Rolly ball and flatten the surface using a rolly ball and flatten the surface.
Venous bleeding cannot be cut.
It cannot be stopped.
Venous bleeding cannot be cauterized by anything. If you try to go near and near, it will again
More tear will be there.
So just stop the procedure, place the catheter,
and give
the story is over.
Inflate the balloon.
If you are
what sir is trying to say is that if you are beginning of the procedure, it is better to abandon. But if you have a little bit of the gland left, then quickly finish it.
You can quickly finish it. Yes.
And put the catheter.
Yes.
And bulb of the catheter should be in.
Bulb
of the catheter should be
in the prostatic fossa.
No.
Why catheter is placed? Why
Sorry, bladder neck. Sorry, bladder neck. At the bladder neck. Sorry.
Why?
Remember, your traction is always at bladder neck.
Yeah.
Never
Because
comes in prostatic fossa.
the feeding vessels come at 5 and 7 o'clock.
It helps to collapse the fossa. So 5 and 7 o'clock.
So
bleeding stops.
Complication of TURP or some few points about bipolar TURP again.
Complications of
commonly done all over the रख सकते हैं bipolar का.
Complications could be divided into intraoperative complications. So it could involve initially while obtaining access, creating a false passage, creating a false passage in the urethra. Second could be while doing the surgery, excessive bleeding. Then intraoperative damage to the sphincter, sphincteric injury. And then we have undermining of the bladder neck. Then TURP syndrome intraoperative also. Post-operatively, again bleeding, TURP syndrome, electrolyte imbalance, that is TURP syndrome, and post-op sepsis, and then late complications could be divided as stricture disease and bladder neck stenosis and failure to void.
Two questions. How many TURP syndrome you have seen, and what is the common site of stricture? Commonly asked.
So what are the first question, sir?
How many TURP syndrome you have seen in last 3 years?
Only one, sir. One.
I
have seen only one, sir. I had seen one patient.
How do you TURP syndrome intraoperatively?
So intraoperatively, if the patient is under spinal anesthesia, then the patient might have disoriented talk, might have nausea, vomiting. And looking at the monitors, there will be bradycardia and there can be...
patient will be disoriented right from the beginning. What is the first sign of TURP?
So bradycardia and hypertension.
Yawning, sir.
Yawning, man.
Yeah,
Yawning. Patient starts yawning.
Yawning.
So how will you reduce the TURP syndrome? What is your strategy?
Initially, make sure that first is that if you are having a larger size gland, so you will like to stage the procedure first. Second is maintain the flow. Third is
why you want to stage the procedure? Because there are a number of options available in front of you.
Yes, sir. So depending on the
so proper selection of patient.
Proper selection.
Means what? Means what?
Means if it is a larger gland, then we can laser surgery.
Patient should be fit, system should be sterile, and size should be amenable for resection within a 90 minutes. 60-minute resection and 30-minute coagulation. So it should not go beyond 90 minutes. Proper use of irrigation fluid. Preferably 1.5% glycine. Water can be used.
Glycine.
Okay.
Yes.
Then another, if you have an option, try to go for bipolar. In spite of monopolar. Why bipolar? The small vessels while cutting get cut and coagulated, and vision will be more. But literature wise, the reported rate of stricture, few literatures suggest that the stricture rate is more with bipolar than the monopolar.
No.
Okay.
Absorption of fluid will be normal saline, isotonic.
And the use of fluid will be normal saline. So when you
Normal.
use laser,
Say the size of the gland is more than 80 grams, patient is on blood thinners and which cannot be stopped, then we will use lasers.
okay.
What about pacemaker?
One.
What about pacemaker?
Pacemaker also we prefer either laser or bipolar.
So what is
No,
difference
so
between monopolar?
can otherwise TURP done with a pacemaker?
Yes, sir. It can be done. Either change the setting, so we will have
Call the guy, call
the guy and change the
company
setting.
person. Yeah.
Yes, sir.
Yeah,
Change
he
the mode.
will help you paste the thing again.
Yes, sir.
And
After
where
laser
will you put your
prostatectomy,
cautery?
Yes, sir.
Your OT personnel, he's putting the cautery pad. So he's put it now under the left shoulder. What you
No,
will
so
tell
we'll
him?
ask him to put it under the buttock because
Buttock,
buttock. Yes, that will not farther from the heart. So that it would be under
If
the
you're
buttock.
doing a bipolar TURP, does it matter if the patient has
No,
a
bipolar
pressure?
TRP, there will be no electrode. If you are using a monopolar, we don't have option of bipolar, then this precaution that change the mode
Bipolar and laser can be used with pacers.
Yes, sir.
With pacemaking, right? So one more
Why there
question.
is-
Sir had asked you what is the sorry. Sir was asking.
why there is strong dysuria or chance of more dysuria in after laser surgery? Why? Means patient comes with irritative symptoms for 3 months after laser, and not in our usual TURP. This one. Have you noticed this? Laser TURPs, irritatives. This one, the strong dysuria is there.
More in which laser? Which laser sir is talking about?
Where
patient is not HOLEP. KTP, man, where you burn the fossa so much that there are a lot of storage symptoms.
देखो, any storage symptom post TURP, any type of TURP. That means when you resect the trigone, one, if the loop, the part of the gland is hiding behind the trigone, and if you have to resect that trigone, there are chances of having a more storage symptoms post-operatively, and that's why we usually, in spite of doing a TURP, the storage symptoms may not disappear in 30% of the patient. That is one reason. Another reason is if you charge that system, everything is get charged in KTP.
Yes.
If you use more coagulation in such situation, there is a, as sir is told, there is a more dysuria for longer period.
Yeah.
So answer of laser is
Patient has an overactive bladder already from the beginning.
you are going right up to the trigone.
Yeah.
Dr. Huddedar has asked you, why there is a dysuria, why there is a storage symptoms after laser.
Correct. Sir is right that they over resect sometimes with the laser. And for that patient already had mixed symptoms. He already had storage symptoms. So sometimes you have to tell them that voiding symptoms may improve, storage symptoms may require medical management post-operatively.
Yeah.
Just one continuation question with what Gite sir asked there. How much is the fluid absorption in TURP?
So 20 ml per minute.
And
So
how
if
much
you
is it
resect
in
for
PCNL?
Yes, sir.
How much is it in PCNL?
PCNL.
Can you get TURP syndrome post PCNL?
Yes, sir, we can get.
Yes, so you should know how much is the fluid absorption after PCNL. Gaurang Shah sir will tell us.
See, when you are not going outside, we are using saline first of all. So in PCNL, we never use water. Okay, so you will not get it. Second thing, we are always where is the fluid?
So in the
You are in
PCS.
the callus system, pelvic callus system.
Yes, sir.
So from the pelvic callus system, usually there is no absorption. So if the pressure is not very high and the fluid is continuously coming out, how often you have seen TURP syndrome after PCNL?
Not seen. Not seen.
Then
So
because
why
also
sir is
you are
telling
using
that? Because it's a low pressure system. When you have amplar sheath, the fluid is
Amplar,
nicely
yeah.
coming out. But if
so
it
the
is
fluid is
snugly
coming
fitting
out.
and it is a tight system, and you are using the wrong irrigation fluid, definitely you can see TURP syndrome. But because we are
So
using normal saline, low
if
pressure
you are
system,
outside, what
yes sir,
Hiren
yes.
is
If you are
asking you,
nicely, yeah,
okay, if your sheath is outside, if you are in the
Yes.
parenchyma, and if you are using water, okay, there will be extravasation as well as there will be absorption. But if you are using saline, if your implant is of little bigger size than your telescope, there is a continuous irrigation. Understood?
Yes.
There will not be any fluid remaining inside the pelvic LSL system. And pelvic LSL system is what? There is no absorption of fluid from there. Hardly anything. You understand?
Okay.
So that is
so
why
in PCNL, the irrigation fluid absorption is about 3 to 5 ml per minute, and in RIRS it is 1 ml per minute. So if you're doing RIRS for 60 minutes, about 60 ml of fluid is absorbed. So you are safe to do it for
that's
60
under
to
pressure.
90 minutes. Yeah, yeah. Under gravity, I mean, it should not be more than 40 centimeter of water from pubic symphysis.
Yes.
Suppose 1 liter of fluid get absorbed, then how much there is a drop in the sodium level
So
per
three,
liter of the fluid?
after 1 liter, na?
1
3
liter.
to 5 millimoles, sir.
5 to 8 millimole per liter.
5 to
5 to 8 millimole
5,
per liter.
5 to 8 millimoles.
Another question was just how many TURP you have done in last 3 years?
So quite a few I have done, sir.
Okay. So what are the complications? This question was asked in n number of times.
Yes.
Because my purpose of asking the question is different. It will come out. So what are the complications in your that few cases?
Uh,
So usually no complication. Okay. And then examiner will get
You can
you don't have
see,
any complication.
you can say simple things that in one case I couldn't control the bleeding, sir. One case I was lost in the plains when I was in the beginning,
Same
and
question
I
was
was
asked
not.
by Dr. Nitin Kekre in my exam. And I told
Yeah.
I have done 100 TURP. Okay, that is true. Before going to training, I am doing the urological job with some another urologist for 10 years, 5-6 years before going for training. तो मैं सच था बोल दिया तो suddenly he gets shocked. 100 TURP. Which center you come from? So XYZ center. Then what are the complications? Few times bleeding and 1 or 2 capsular. Oh, you are great. You are better than me then now. So I recognize that I am going digging myself. I am doing TURP only for 30 gram. So more than 30 gram, I am referring to my boss or I am calling my boss. Then he will like, oh, that means you are safe to the society.
yes.
So this is a trick exam. कि examiner का क्या mood है वो read करना है.
Yes. Yes, sir.
These are
Thank
very
you.
practical points what sir
Yes,
is
sir.
telling, because
Yes,
this
sir.
is
Thank
how
you,
the
sir.
exam will happen. You don't boast out there, but at the same time you tell some complications that I
Yes, sir.
couldn't control the bleeding. I called my teacher and I was lost in the plains, or maybe I made one deep cut and then I got scared and I told sir. So then we quickly finished the procedure. These are the things happen even in today's practice. Sometimes we may over receive. So it is not no.
Yes.
So
Yes.
just what we
Nobody's
can
God here.
say
But at the
to
same time, you
not
have to be
to
humble.
you, but to all the residents, that you say, okay, sir, we have done about, you can say 25, 30, but all the TURPs we have not resected totally. In the beginning, we have done it, and later on, the boss or the consultant will take over. And
Yes.
even in that, I have come across the bleeding, and I have come across couple of times going very deep up to the sinus. So we had to
You
put
can
the
simply say that it was done by
so the
under
examiner is
supervision.
very happy. Examiner knows that you have done many TURPs, but not the full TURPs, and you have come across a complication. So you know, okay, how to be safe.
Yes.
And this is the truth, isn't it? That is how sir gives, na?
Yes,
Sir
sir.
always is standing there, na, with you. So it is
Yes.
always under supervision. What Gaurang Shah sir is telling, that is the reality. That is what we are all doing. No? How we
That
have
is
all
the
learned. Like that only.
pattern of training in as per the DNB also. So observe the TURP, done under the observation and done independently. These are the three categories.
Yes.
Okay, fine. Now, Abhishek,
See
your
one,
turn.
do one. See one, do one, teach one. Sir, where is that fellow hiding? Prashant. Prashant, where is he hiding, sir?
Okay, Abhishek.
Yes, sir.
Dresden.
Yes, sir. Sir, this is a Dresden type of nephroscope, sir. Sir, it is manufactured by the company Wolf, and yes, sir, it is used for primarily for PCNL, sir, and it has a sir. It has a thumb mechanism in between the viewing system and the scope system, sir, for better gripping and for better stability during the procedure, sir.
It is based on which the idea has come from where?
Sir, the idea is of two prisms, sir. Two prisms
Where is it come
reflecting
from? Sir is asking.
Used. Where it is used?
Underwater somewhere, some kind of boat
periscope.
equipment
Yes, sir. Yes, sir.
underwater.
Periscope. Yes, sir.
Periscope. It has come from the periscope.
Periscope. The
Offset, you
principle.
should have said. I
Offset,
was
okay.
expecting you to say offset type of optics. So
Okay,
then
right.
then you can say two prisms, right? So it's a
Right, sir.
offset. Yeah.
Right, sir. Yes, sir. So it has an optical pillar,
What
sir,
are the
and an eye.
uses of this nephroscope?
Sir, uses of the nephroscope, primarily it is used for PCNL to visualize the tract and remove the stone fragments, sir. Primarily used for PCNL. Otherwise, sir, the nephroscope can also be used for removing either parts of stone or, sir, broken VIU knife in the urethra, left behind foreign particles in the urethra, sir.
So that is an uncommon thing. I mean, you should tell the common things first. So you can say
Suppose
PCCL, right? You can say PCCL.
why you want to use nephroscope in urethra for removal
You
of the
are
blood?
saying some uncommon things. See, first is
So
PCNL, then second is
in spite of
PCCL.
that, you should have tell it can be used for PCCL. It can be used
PCCL.
for cystolithotripsy in female.
Cystolithotripsy, then you can say morcellation. Common things you are not saying. Then you are telling some broken piece of knife. How many broken piece of knife you have seen with nephroscope?
Tell common things first, and more than try to say the rare things.
So all the common things you know now: PCNL, PCCL, then cystolithotomy is treated in female. Then you can say post-HOLAP we are doing morcellation using nephroscope.
Yes.
Yes, sir.
True. So,
So,
what
what
has
are the
shown
sizes?
sir has shown that nephroscope, that is Dresden. What is the size of Dresden?
Sir, 20 French, sir.
Then another
What are the
question.
different types of nephroscope available today?
Sir, different types of nephroscope available. One is Dresden type, sir. One is Marburger type, sir, which has an offset eyepiece, sir. And one is lateral viewing type, sir. I think Marburger is
Correct.
manufactured by Olympus, and the lateral viewing type is manufactured by Stores. Yes, sir. And Dresden type is manufactured by Wolf, sir. I think there is one straight. I'm not sure, sir. I don't know. I just read
So
it,
do you
sir.
know all these mini, midi, micro PCNL, mini PCNL, midi PCNL? Do you know what
Yes,
are the
sir.
types of scopes available?
No.
You must know, because if
Yes, sir.
some examiner might
classification of
he will definitely ask you what is mini PCNL,
yes,
micro PCNL.
Mini PCNL
Yes,
is
sir.
what type?
Mini PCNL is a sir access track less than 19 French, sir.
So normally which are we are getting?
Okay, and
14 and
Sir,
16.
normally we are doing standard PCNL, sir, with an Amplas sheath of 24 French, sir, 24 to 26.
No, mini PCNL. What is the normal size you are getting? The telescope size is what?
Telescope size, sir, I'm not sure, sir. I don't know.
Prashant is helping you, see.
15 by
Yes, sir.
18, 15 by
Sir,
18,
right,
15.5 by 19.5, and 21 by 24.
right, sir.
So these
You
are
must
the
know it, because now there is so much advances in PCNL.
Yes,
You must know these things. PCNL discussion can go anywhere.
yes,
मिनी
What are the
माइक्रो
different?
सबका तो जो साइज है वो पता रहना चाहिए. What is by
yes, sir.
conventional PCNL, what is by micro PCNL, mini PCNL, ये सबका साइज पता रहना चाहिए.
See, such a
Yes.
nice diagram they have put. Somebody has put already. So mini
This is
PCNL
all paras.
14 to
Paras
20.
is
Yeah. Micro is 14 French, 11 to 13 is ultra mini, then mini is 14 to 20, and standard PCNL is 24 to 30. So तुमने standard बराबर बोला, 14 to 20 is mini, that also you told, but you said 11, I think. So 14 to 20 is mini. That is what you should know.
Yes,
Ultra mini is 11 to 13.
What is the
yes.
size of universal nephroscope?
19 French, sir.
Correct.
19 French.
I think 19 French, sir. Yes, sir.
Universal nephroscope.
I think 19 only, sir. I'm not sure.
that is what you are talking about is a higher size of the mini PCNL 20.
24 French is a universal nephroscope. 24 French.
Okay, sir.
So tell me, Abhishek, what are the different types of energy sources you know that we use in PCNL?
Okay, sir. Sir, energy sources, different type can be, sir, sir, lithoclast, which is based on the jackhammer effect, sir. And other most commonly uses a laser, sir, for breaking of stones, sir. Other than that, sir, ultrasonic can also be used, sir. And combined energy source can also be used, sir. So most
What do you
commonly
mean
used,
combined energy source?
sir, mechanical as well as ultrasonic, sir.
What are the new devices which are using that combination of energy sources? Which lithoclast you have used?
Sir, standard lithoclast, sir.
Which company it was?
It's made EMS.
EMS,
Company,
right?
I don't
So
remember. Okay, okay,
EMS
EMS.
people have made new one, no? That was a Swiss lithoclast master.
Swiss
So what is the
lithoclast
new?
master and cyber,
Yeah.
cyber one.
So now
cyber
what
one,
is the new technology?
Thunderbeat also, I think. Shock pulse and Thunderbeat, yes, sir.
Shock pulse.
Somebody's written shock pulse. What is shock pulse?
Sir, shock pulse is the combination of mechanical and I'm not sure, sir. I'm unable to recall.
Pulse and trilogy is the same thing. Trilogy is what is the EMS people have made, and shock pulse is what Olympus people have made. Right.
Right,
So
sir.
it is a combination of ballistic, ultrasonic, and suction.
Right.
Therefore, they call
Yes,
it
sir. Ballistic
trilogy.
and ultrasonic. Yes, sir.
So what is the new effect? What effect is it called when you're using mini PCNL and you're using laser? How the stone pieces are coming out on their own? What is that effect called?
So I think it's capillary effect, sir, between the scope and the ampla sheath, sir. Turbulence is created. Turbulence is created, and the principle, I think, is Bernoulli's principle, sir. The
Minor effect, basically, it is called in common language. So it creates that whirlpool effect by which
yes,
the
sir.
stone pieces come out on their own. All these new advances you must know because they will ask you.
Yes.
So
in mini PCNL, what kind of amplet sheet do you use? So it comes like a single dilator. Okay, so first you use
Right,
your
sir.
facial dilators, and then
Right.
directly use that single dilator with the metallic amplet sheet which they come. It comes with that.
So tell us the different parts, the different instruments that you will use for a PCNL.
Okay, sir. Starting right from sir, the
Cystoscopy is
ureteric catheterization, sir.
everything is done.
Yes, sir.
Which position you would like to operate?
Sir, I would like to operate the
Prone?
patient. The prone, sir. I have seen prone only, sir.
Yeah.
And I would want to operate the patient in prone position. So various instruments starting right from the puncture are a standard 2-piece or a 3-piece needle. Three-piece needle does not, sir. What you're
What is this
showing
called?
is,
What is this called?
sir, it's called a Chiba 3-piece needle, sir.
Uh, uh, Chiba needle is what? 27, 28 French.
Yeah, अपना usual 2-piece है.
That is used basically for paper.
Sir, I think this is
This is
3-piece, sir,
three-part
because
Gunter needle.
this is 3-pass. Yes, sir, 3-part.
Three-part Gunter needle.
Okay.
Three-part GUNTER Gunter needle.
Okay. Yes. And
Okay.
the tip, yes, sir, the tip of this needle can be a diamond tip or a bevel tip, sir. In this case, I can't see the tip, sir. So looks like a diamond. Looks like a diamond tip, sir.
Abhishek.
Yes, sir.
When that question is asked, your answer is initial puncture needle.
Okay. Right, sir.
So in spite of getting into trouble, answer is initial puncture needle. If
Right.
they suppose that the tip is of diamond or trocar shape, then which needle it is?
Sir, Chiba needle, sir.
No, Chiba needle is bevel tip. Chiba needle is always 3-part bevel tip.
Right.
Okay, so Gunter needle,
Right.
what it is telling is
Gunter needle. Okay.
diamond shape or trocar tip needle.
Right.
The size of the needle used is 18, 20, and 21.
Yes.
So as per your practice, जो भी use करते हो बोल देने.
Yes, sir. 18 gauge needle is used, sir, so that guide wire of 38 can 0.0038 inch can be used, sir, with that needle.
Inch?
And 0.0038 inches, yes, sir.
Point?
क्या बात
0038
का 38
इंचेस कैसे रहेगा यार? उसका क्या रहता है? 0.035 0.038 क्या रहता है?
Sir, inch. I'll
ठीक है, चेक करो.
Yes, sir. I'll check, sir. Inches ही रहता है, sir, I think.
What is this? 0.035 is what?
Inches, sir. It's 0.0035 and 38 are inches, sir.
अरे भाई.
Yes, sir.
इंच कैसा रहेगा? इंच कहाँ पड़ा कौन से इसमें? क्यों रहेगा?
Sir, I'll confirm, sir. I'll find out.
मैं confirm करता हूँ, लेकिन मुझे नहीं लगता इंच होगा बल्कि.
Right.
Here many people are saying inch. So let us find out.
Okay, we will find out and we will tell. No problem.
Yeah.
आगे.
Right, sir. Sir, then guide wire is used, sir. In my center, Terumo guide wire is used. And sir, next, sir.
What are the problem with Terumo guide wire?
Sir, the problem with Terumo guide wire is, sir, sometimes when the stone is large, sir, the Terumo guide wire cannot be negotiated beyond the stone, sir. When there is limited space between the system and the stone, sir, the Terumo guide wire cannot be negotiated beyond the stone into the ureter, sir.
उल्टा बोल रहे तुम. उल्टा Terumo has a tendency to find the way.
J-tip, sir. J-tip wire, I think then. Okay, sir. And other than that, sir, Terumo guide wire loses its reusability after the hydrophilic, the coating, outer coating gets worn out after a few uses, sir. That is a problem and difficulty in handling, sir. Yes, sir.
Correct. And whatever you are telling, that inches is also correct.
Correct. वही तो मैं बोल रहा हूँ. Correct.
Point 0.018 to 0.038.
038. 38, 35, 25. They are inches. Yeah.
Yeah. True. He is telling the correct.
Correct. बराबर है.
Right, sir. Then later on, sir, facial dilators are used, sir. Facial dilators are used till 8 French. And then, sir, and after dilatation of the tract till 8 French, sir, an Alcan rod.
What are the types of dilator?
Okay, sir. Sir, the types of dilator include, sir, sequential facial dilators, sir, or they are also of a
What is
coaxial.
this?
Sir, this is a facial dilator, sir.
So it starts from?
So it starts from 6 French, sir. Six French, 8 French, 10 French, and thereafter, sir. Yes, sir. Sir, then another type of.
Abhishek,
Yes, sir.
when asked this question, what are the types of dilators? You say there are two types of dilators. One is for facial dilatation and other is for tract dilatation. Facial dilatation can be sequential dilators or can be a coaxial dilator.
Coaxial dilators.
So,
Sir, then where to include the balloon dilators and screw dilators?
to remember the types of dilator, you have to remember B fast. B fast. B means balloon dilator.
Yes,
S
sir.
means facial dilator. A amplas dilator. S means screw dilator. And T means telescoping metal dilator or alkane telescoping metal dilator.
Yes, sir. Yes, sir.
So it is all 5 types of dilator. Again, it is depend upon the place where it used. What the sir is telling us. So if it is used for the to dilate the fascia, then it is the facial dilator.
Facial dilators.
And
Yes.
all things are track that dilate the tracks. That screw dilator is initial one which can go from skin to the pelvic system or where you want a puncture or up to what place you want to dilate. And arm plus also for same, telescoping also same, and balloon dilator is also same. So except facial, all other dilators are track dilators.
Yes, sir. So Shah's one-step dilator रहता है सर.
वो तो कहीं पूछा तो बताओ.
Okay. ठीक है.
वो theoretically described है वो these are the only 5 types.
Okay, sir. Yes, sir. And then, sir, after dilatation, sir, ampla sheath is used to maintain the tract. And yes, sir.
Tell me
After
about
that,
this. Before talking about ampla sheath, tell me about this metal dilator.
Okay, sir. These are coaxial facial dilators along with the alkanes rod. Sir, the coaxial alkanes rod is 8 French, sir, and thereafter with a difference of 3 French, 3 French, the coaxial dilators continue till sir, a dilatation of 24 French dilator, sir. And yes, sir.
Maximum
30.
30. Yes, sir. And yes, sir. These are stainless steel dilators, sir. And these are concentric dilators, sir. Coaxial dilators means one dilator can be.
Or you can say telescope.
Yes, sir.
I mean,
it is
all one into another.
Telescoping dilator with central rod. Alkane coaxial telescoping dilator with central rod.
Right.
Now I'm holding the rod. The dilators are not falling down. Why?
Right, sir. Because there is a bulb at the end of the at the patient end of the alkanes rod, and the coaxial dilators are tapered towards the end, such that the last dilator sits on the alkane bulb, the bulb of the alkane rod, and thereafter the next coaxial dilators sit one on top of each other, and the tip is stopped by the bulb of the alkane rod, sir. So that is why it does not move.
This bulb, okay?
Yes, sir.
That stops only the first dilator. After that, other dilators are stopped by this cannot go. Why? Because there is a ring here at the end.
Yes, sir. Okay.
This ring stops.
Right, sir.
Understood?
Right, sir.
And that rings helps in gripping the dilator also.
And here there are grooves. These grooves helps you to rotate. And
yes, sir. And grip. Yes.
Inside there is you cannot see it very clearly. Next time you go and see.
Yes.
So the first dilator is stopped by this bulb. The first dilator is stopped by this bulb at the tip. And this helps also in easy negotiation without any trauma. over the glide bar.
Yes.
So
So
that
what
is
is
why this rod. The first dilator is stopped by this, but after that, all the other dilators are stopped by a small ring at the distal end.
Right, sir.
That is why if you hold it like this, it doesn't fall. But if you hold
Doesn't
it,
fall.
it will fall down. See, this will fall down. This will fall down. So you
Yes.
tell sister to hold the rod and not the
Rod,
dilator.
not the dilators.
Okay.
Yes.
so the length of the rod and size of the rod?
So what are the
Sir,
advantages? Yeah, you tell us.
sir, the size of the rod is 8 French, sir, and the length of the rod is, I think, 110 centimeters, sir, I think.
अरे उतना बड़ा?
नहीं, वो तो गाइड वायर का, सॉरी सर, 70 centimeters.
No, 70. Okay.
70
No,
centimeter. I was
50,
confused.
50.
58
50.
centimeter. 58
Okay.
centimeter the length.
58.
7 French is the size of the rod, and 9 French is the size of that the tip को जो रहता है ना rounded knob, उसका 9 French है.
Right.
And rod का है 7 French. And
Right.
जो telescoping dilators है वो है 9 French से
Dilators are
शुरू
9
होती है.
inches.
9 से above.
Dilator length is 9 inches, and the rod length is 20, almost 22 inches. Okay.
Okay, sir. Okay, sir.
So 22 inches is how many centimeters?
22.
44.
44.
55 centimeters. 55.
55. Approximately
55, yes, sir. Approx 55.
Okay.
Yes, sir.
Fine. Okay. What is
So
the
there are-
advantage of these over the serial dilators?
Sir, in serial dilators, the disadvantage is sir, during the sequential change of the dilator, sir, guide wire may get misplaced or come out of the system, sir. And sir, the basic advantage of this coaxial dilator is maintenance of the track and some amount of hemostasis also, sir.
Yes, hemostasis is the most important thing.
Yes, sir.
Fine. Okay.
So yes, sir. So then, sir, Ampla sheath is used to maintain the track, sir, and then, sir, nephroscope is used,
What else?
and then
What else? Maintain the track. Second thing is
maintain the track, tamponade, hemostasis, and for the
Low
removal
pressure.
of low pressure,
Low pressure
maintenance. Yes, sir. Continuous maintenance
prevents
of
the
low
extravasation and the
intrarenal
low
pressure.
pressure.
Yes, sir.
And the last is extraction of the calculus.
Extraction of stone particles. Yes, sir.
What are
And
ठीक है, बोलो.
yes, sir. So thereafter, nephroscope is used along with lithoclast in my center. Stone is fragmented, and with the help of forceps, the stone fragments are removed.
Okay, what are the problems with that alkane dilator system?
Sir, the main problem with the alkane dilator system is the counter perforation of the pelvis, sir. In overdilatation, sir, in overdilatation, the pelvis may be punctured by the perforated by the alkane rod, sir. And sir, during screw dilatation, sir, during concentric facial dilatation, concentric dilatation, sir, hemorrhage is also a problem, sir.
And kinking of the wire.
Yes, sir.
And what are the problems with Ampla's dilator system?
Sir, problems with Ampla's dilator system.
Because the tip of the dilator is 1 inch conical.
Yes, sir. In
So
Ampla's,
track
yes, sir.
get under dilated. And if you are planning for serial dilatation, then you have to dilate, then come out and use another one, then dilate, come out. So in between there is the chance of bleeding. So if you use a single ampullus dilator, it's okay. But if you are dilating with serially with increasing size, then you have to again go in and come out. So that is time consuming as well as chances of bleeding.
Okay, sir.
So these are the drawbacks of the
Ampullus system.
dilator. How balloon dilator works?
Sir, balloon dilator, ampullus sheath is pre-planted onto the balloon dilator, and the dilator on the guide wire is passed along to the dilated tract, and the balloon is inflated, sir. And once the balloon is inflated, the ampullus sheath is passed over the balloon to maintain a tract.
My question is how balloon dilator works means if you dilate that balloon, that will work by lateral compressive force.
Okay.
Okay. And in rest of the system, it is a shearing force.
Okay. Yes. Understood.
Okay. But it is better now. Why we use balloon everywhere? Why you want to use that alkane dilator and facial dilator? And these are very easy lateral compressive force, no bleeding.
I haven't seen balloon dilatation.
Post-operative patients, patient having any history of operation prior. Okay.
Right.
If there is dilatation with balloon in a patient having a fibrosis along the tract, possible?
Yes.
It is not possible easily.
Difficult,
This,
sir.
it is better to have a alkane telescopic shearing dilator. These
Yes.
are the metal dilators.
Yes.
Okay. So that's why
Yes.
balloon dilator is not useful in each and every condition as
Right.
and cost. And balloon कितना बार एक दो तीन बार यूज कर दिया तो फिर बाद में फेंकना पड़ेगा, फूट जाए, वेयर एंड टियर भी.
Right, sir.
बाकी PCNL में सिचुएशनल एग्जाम में पूछ सकते हैं कि if wire is not going, calyx is full with the stones, then only tip of the wire is gone, then how will you try to, what are the tricks of passing the wire across the stone when the calyx is full up loaded with the stone? Wire is not going, then the needle wire gone, incidentally wire come out, then contrast placed and there is extra oscillation. So in such situation, what you will do? These are the common questions asked when there is a PCNL discussion is going on. So that will,
Yes.
if you answer that question, that will indirectly suggest that you have done or observed or assisted the PCNL. Otherwise, सबको आती है.
Yes.
Fine. I think we should stop here. Gite sir?
जी सर, आप जैसा बोले वैसे, मेरा मुझे कुछ.
Yes, I think more than 2 hours are over. So
Okay.
whatever is remaining, small other things will take up next time. Correct?
हाँ, तो एक लोअर ट्रैक में मेरे ख्याल से ओटिस यूरोथ्रोटोम रह गया है.
हाँ, ओटिस है मेरे पास.
रह गया और बाकी PCNL से ही कंटिन्यू करेंगे उस दिन.
PCNL and URS.
PCNL and URS. एंड अपना हिरेन सर को बोलेंगे फ्लेक्सिबल पे थोड़ा सा, कभी
Sure.
Yes, and by that time even Maheshwari will be free.
Yeah,
you know.
hopefully. एक हफ्ता है तो हो जाएंगे.
And but we wish her,
convey to all your
recovery.
friends that next time there is a talk
Yes,
on
Ojas and Ghosh.
Yes, sir.
Abhishek, I
Yes,
don't
sir.
want two of you to answer. You have to find out now. Other
Okay, sir.
candidates.
Yes,
in
sir.
this 7 days. Let
Yes,
others
Right,
answer.
sir. Right, sir.
Okay.
so next Tuesday there is a talk on overview of research.
Yes, sir.
Right, sir. Right.
Request
Tell
everyone
everybody
to attend
it's
because
important
it will
talk.
be very helpful in your DNB thesis also. Not only that, even in the exam. Even if
Yes.
it may be useful for 5 marks or 10 marks, but it is really useful.
Yes.
Okay, sir.
Okay.
Yes, sir.
Fine.
Okay,
Yes.
thank you. Good night.
Thank you all the teachers.
Thank you, sir.
Right, sir.
Good night, sir. Good night, all
Good night,
teachers, sir.
Gite sir,
Thank you, sir.
Thank
Gaurang
you, sir.
sir.
Thank you so much. Thank you all the
Well
teachers.
done,
Hiren bhai,
Abhishek.
thank you very
Well done,
much.
Thank you, sir.
Ojas.
Thank you, sir.
Thank
Well
you,
done,
sir.
all those who
Thank you,
presented.
Hiren sir.
Prashant, stop hiding. Good night.
Thank you, sir. Good night, Gaurang sir.
Thank
night,
you,
Hiren
sir.
sir.
Thank
Good
you,
night,
Hiren sir.
Uday
Thank
sir.
you,
Good
Gaurang
night,
sir.
Hiren
Thank
sir.
you, Ganesh sir. Thank
Thank
you,
you.
Anil sir. Thank you, sir.